Hi class, in this lecture we will review adrenergic drugs.
So just as a quick reminder, the four different adrenergic receptor types are alpha 1, alpha 2, beta 1, and beta 2. And, again, these specific receptor types tend to be located in specific types of end organs. So alpha 1 are in the blood vessels, the bladder, the liver, the pupils. Alpha 2 are in the CNS. Beta 1 is in the heart. You can remember that easily because you have one heart. Beta 2 are in the lungs. It's easy to remember that because you have two lungs, right? But beta 2 are also located in blood vessels, liver, bladder, GI tract, and the uterus. So let's talk about the adrenergic drugs. We have two classes that we'll review. They are the adrenergic agonists and the adrenergic antagonists. So let's start by reviewing the adrenergic agonists. Adrenergic agonists are also known as sympathomimetics because remember, adrenergic means sympathetic nervous system, and agonists in the sympathetic nervous system are going to mimic the effects of the sympathetic nervous system. That's why we call them sympathomimetics. Another name you may hear is catecholamines. This is a little misleading because not all adrenergic agonists are technically catecholamines. When we get to the group of adrenergic agonists that are catecholamines, I'll point that out. But just so you know, that's another term that does tend to be used for adrenergic agonists. There are four receptor types. Just to remind you, we already talked about this when we talked about pathophysiology, but there are four receptor types, and the location of these receptor types of the adrenergic receptors does vary by organ. And when we when we begin talking about the drugs, you'll see that the specificity for each of these different receptor types will vary by drug as well. Please don't be afraid of this table. Really, I'm just including it to kind of illustrate the point that not only do you have the receptors located in different organs, but the drugs themselves also have selectivity for those different receptors. So not every drug will activate those different receptors equally. And that's what the table 17.2 from your book is basically depicting. So you don't have to necessarily memorize this, but I do think it would be wise for you guys to look this over and kind of, become familiar at least with, where the different drugs act according to the specific receptors. One thing to point out is that dopamine is included in this chart. Dopamine, which is one of our adrenergic drugs, acts at the dopamine receptor. I haven't really talked previously about dopamine receptors, but dopamine acts at alpha 1 and beta 1 receptors, which are part of your adrenergic system. But there are also dopamine receptors as well, which we will probably talk about those just briefly. So this is just another representation of the previous slide. And again, don't get too overwhelmed by this slide. The point of this is to show you the receptors and the fact that some of the drugs will activate some receptors but not others. So, for example, epinephrine and norepinephrine, you can see that they activate alpha 1, alpha 2, and beta 1, and then epinephrine can also activate beta 2. So if you look at the drugs and which receptors they activate, from that knowledge, you can estimate what the effects of using that drug would be. So the other thing I did on this slide was I highlighted in purple drugs that are pretty specific for a particular receptor. So alpha 1, phenylephrine is a medication that mostly activates alpha 1 receptors. So in essence, it's kind of a prototype for what happens when alpha 1 receptors are activated. So the effects that we see when alpha 1 receptors are activated is vasoconstriction. Again, if you go back to the pharmacology of the autonomic nervous system, and as long as you understand the sympathetic nervous system, these effects will make perfect sense. So vasoconstriction, it can happen in the veins, the skin, the viscera, the mucous membranes, but really where we see the effects that are of concern are vasoconstriction in the veins. And so in terms of the uses, we use phenylephrine and also epinephrine, norepinephrine, and dopamine, to increase blood pressure, usually kind of in the setting potentially of shock. Also for managing superficial bleeding. So so phenylephrine in particular can be used topically to manage superficial bleeding, and phenylephrine is also used topically to reduce nasal congestion. The adverse effects that we worry about, specifically when this is given systemically, so when phenylephrine or epinephrine or norepinephrine or even dopamine, when these are given as continuous infusions specifically to increase blood pressure, we worry about necrosis. So necrosis occurs because of the potent vasoconstricting properties of these medications, and when they're given intravenously, if that IV becomes dislodged and the medication spills into the surrounding tissue or extravasates, it can cause necrosis. So necrosis is a big concern. The other thing we worry about are cardiac complications like hypertension or bradycardia, and that's because the body, as you guys know, the body has lots of different feedback loops. So the body detects that vasoconstriction is occurring, and that vasoconstriction is um, influencing blood return and so forth, and the body compensates for that by increasing or potentially affecting heart rate and other heart-related parameters. So the body compensates for that in a variety of ways. So what we can see as a result of that vasoconstriction and those compensatory reactions are hypertension or bradycardia, and they can be concerning. The alpha-2 blockers, I'm not going to talk about these because I'm sorry, not alpha-2 blockers, alpha-2 agonists. I'm not going to talk about these now. I'm going to save those for the end of the discussion. But just so you know, epinephrine and norepinephrine do activate alpha-2 receptors. But there's really the effects of activating alpha-2 receptors in the peripheral nervous system is really inconsequential, so we won't really talk about that now. Towards the end of this lecture, I will talk about alpha-2 agonists that work in the brain. I'll talk a little bit more about those. But for now, let's move on to the beta-1 agonists. So you can see I have a little heart there. Remember, you have one heart, and so beta-1 receptors are found primarily on the heart. Again, epinephrine, norepinephrine, dopamine, they all activate beta-1 receptors, but dobutamine is pretty selective for beta-1. So if we're talking about a drug that's very representative of the effects of activating beta-1, dobutamine is that drug. The effects of dobutamine would be increased heart rate, increased contractility, increased conduction. So essentially speeding up all of the different functions of the heart. We use these for, specifically dobutamine, but some of the others as well, in the scenario of AV block, so the heart is not functioning properly, not pumping properly. We could use these for stage 4 heart failure for patients whose hearts are not really pumping well. In the setting of shock could be due to any number of different issues, but in the setting of shock to, again, increase the heart rate, contractility, and conduction, or in a cardiac arrest situation. So, of course, because of the direct effects on the heart, we would expect adverse effects to largely be surrounding cardiac complications. So, tachycardia, I think that makes perfect sense. The drug itself increases heart rate. Dysrhythmias, again, because these drugs are increasing conduction through the heart. Angina or MI. MI is myocardial infarction. So again, just because of those effects of speeding up the heart and the different functions of the heart. So it makes complete sense. The next adrenergic agonist is the beta-2 agonist, and we'll talk about these. By the way, epinephrine also activates beta-2. So of all of the adrenergic agonists, really epinephrine is the one that crosses kind of all of the different receptors, alpha-1, alpha-2, beta-1, and beta-2. But our prototype beta-2 agonist is albuterol, and albuterol is selective for beta-2 receptors. I'm going to talk a bit more about albuterol in a few moments, but just to have all the information on the same diagram so that you can kind of synthesize it all together, albuterol causes vasodilation. And that vasodilation can occur in different parts of the body where we have beta-2 receptors. Now, the primary place we have beta-2 receptors are in the lungs. So the majority of that vasodilation will lead to bronchodilation. And that makes sense that these drugs could be used to treat patients with asthma or COPD. But beta 2 receptors are found in other parts of the body as well. They're found in the skeletal muscle. So some of the adverse effects like hyperglycemia or tremor, those can result from, especially tremor, can result from vasodilation of the veins, of the skeletal muscle veins. They're also found in the skin, and they're also found in the uterus. So you can see, I have under their therapeutic use, but in kind of small print, there are beta 2 agonists that delay preterm labor. We're not going to talk about them in this course. You'll probably talk about them in other courses later on in your studies. But that is, one of the uses for these medications. And then, like I said, adverse effects, we worry about hyperglycemia and tremor. So specifically when we're administering epinephrine intravenously, it's touching all these different receptors. One of the concerns, especially with intravenous epinephrine, is hyperglycemia. Now, the last line or the last row on this chart, I haven't talked about this previously, but I just wanted to quickly mention this, are dopamine receptors. So dopamine receptors are also considered adrenergic receptors. Dopamine is an adrenergic agonist. I already mentioned that dopamine can activate alpha 1 and beta 1 receptors, but dopamine also activates dopamine receptors. Dopamine receptors are found in the kidneys, and that's why I have a picture of a kidney there. And so these, when dopamine receptors are activated, it causes dilation of the renal vasculature. So dopamine, because of its alpha 1, beta 1, and dopamine activating properties, is used quite frequently in shock. Now, the thing about dopamine, and I'm not talking about the dopamine receptor now, I'm talking about the drug dopamine. The thing about dopamine is that as the dosing of dopamine is pushed higher and higher, it starts to lose some of its ability to dilate the renal vasculature. And so at high doses, we actually see decreased renal perfusion, and that's due to the vasoconstricting effects of those alpha 1 effects of dopamine. So like I said, please don't get overwhelmed by this chart. This is, one more way of displaying this information to try to help you see what the differences are between those receptors, what happens when you activate those receptors, so the effects at those receptors, which drugs can activate the different receptors and why they're used, and some of those potential adverse effects. So I'm going to talk specifically now about the alpha 1 and beta 1 agonists. So thinking back to that chart I just showed you, I talked about dobutamine, dopamine, phenylephrine, norepinephrine, epinephrine, and I said that all of these drugs have different affinities for those different receptors. I'm not expecting you to memorize which receptors they've got affinity for. I think that's, a little bit outside of the scope of this class. I presented it in the last slide simply to help you get a better grasp of the effects at those different receptors. But for our purposes, and I think, for the most part, for your NCLEX, I think it's okay to think of these drugs kind of collectively, and that really when they're used as continuous infusions, dobutamine, dopamine, phenylephrine, norepinephrine, and epinephrine, their primary use is to support cardiac function. So they could be used in many cases in the setting of shock, to support cardiac function and blood pressure. And they do that because of their effects, either their vasoconstricting effects because of their action at the alpha 1 receptor, or because of their beta 1 effects because of their actions on those receptors in the heart. So obviously the vasoconstriction, or on the other side of the spectrum, increased force of contraction, heart rate, conduction, etc. Now, while these drugs are primarily used, as I said, in the setting of shock and other situations where you need to support blood pressure and cardiac function, they can also be used for a couple other uses. Epinephrine in particular is also used intramuscularly, or I suppose it could be intravenously as well, for treatment of anaphylaxis. If you remember, epinephrine was the only drug that could activate all of those receptors, alpha 1, alpha 2, beta 1, and beta 2. For its use in anaphylaxis, kind of across all of those different receptors, especially its beta 2 receptor properties, it can cause bronchodilation, right? So in the setting of anaphylaxis, among other important properties like vasoconstriction and supportive cardiac function, but as well as its ability to cause bronchodilation. So epinephrine is used for anaphylaxis. Phenylephrine, I mentioned this when I was reviewing the chart, but phenylephrine can also be used topically. Because it's a potent vasoconstrictor, it can be used topically, and it could be used as like a nasal spray topically to relieve nasal congestion, for example. Can be used as a vasoconstrictor of the skin as well. So some nursing implications, specifically with the alpha-1 and beta-1 agonists. So when we think of these alpha-1, beta-1 agonists, dopamine, dobutamine, phenylephrine, epinephrine, norepinephrine, like I said, we're thinking of those in terms of continuous infusions that are going to be used to treat shock or to support cardiac function in patients, whose hearts are failing, or patients who have widespread vasodilation and the heart is at risk for failing. So, for these medications, they're going to be IV. They're going to be administered as a continuous infusion. They'll be given via an infusion pump with a programmable drug library, and this will be in the critical care setting. So I recognize that, some of you may not be working in the critical care setting, and the NCLEX, you are expected to be familiar with these medications, but I don't think that you're expected to know as nuanced of information as you would if you worked in an ICU. For those of you who do plan to work in that setting, you're going to have a lot more training, in that specific setting about all the differences between these drugs. I would recommend at that point, kind of as a starting place, going back to that chart that I showed a couple slides back. But again, for our purposes for this class, recognizing that they're used for blood pressure support and kind of in the setting of treatment for shock, looking out for those adverse effects like those cardiac complications, which may be more or less likely depending on how much beta-1 selectivity the drug has. Necrosis, if the drug extravasates when it's being given via an IV infusion, that's huge. You should definitely know that. Hyperglycemia, especially for those drugs that have beta-2 activity, and tremor as well. Identifying high-risk patients, so patients with heart disease, they may not be appropriate candidates for these medications, although, like I said, in many times these drugs are used in the setting of a life-threatening illness. So even if they are high risk, it just means we might be monitoring them more closely for signs of worsening heart function. They're administered via an IV pump, and like I said, monitoring the IV site for extravasation. Also monitoring the EKG and blood pressure, of course, would be important. All right, so let's talk about some medication safety concerns with these drugs. They are considered high alert medications by the Institute for Safe Medication Practices. Like I mentioned, they're given by continuous infusion. They definitely should be administered via an infusion pump that has a drug library. And the drug library just has parameters that if you enter the wrong dose and it's too high or too low, the parameters will stop you and give you a warning and say, hey, did you really mean to do this? And in some scenarios, if the dose you entered is just astronomically high, the pump won't even allow you to program it. And these are just basically risk reduction strategies to help prevent errors associated with these medications. Epinephrine can also be given via a unique dosage form called an EpiPen, and this is for, as I mentioned, epinephrine can also be used for anaphylaxis. So the pen itself, because of the way the dosage form has been designed, has led to errors. In some cases, nurses have accidentally injected themselves with the medication through their thumb, because the way you can see from the picture on the slide, there's a black tip at the top of the product. Kind of looks like you would click that part of the pen, but unfortunately that's actually where the needle comes out. There's a window, and then at the bottom of the device there's a gray activation cap. When you pull that activation cap out, it kind of looks like a needle will pop out. So nurses have been mistakenly, I guess, guided to grab the pen and click the black part. And when you jab this pen into the thigh of the patient, if you were to be holding the black tip, the needle will actually go through your finger. So that's something to, for you all to be aware of, not only because you won't give any therapy to the patient who is in absolute urgent need of therapy, but also because you could yourself be injured, and that can cause necrosis of the thumb or the finger if it accidentally gets injected into that location. So be very mindful of the EpiPen and the proper use of the EpiPen. So this is the newly designed EpiPen. So that picture I had on the last slide, that was the original design, and that design is no longer marketed. But this is what the new pen looks like. And I'll tell you, we still do see reports of these pens being used incorrectly. One of the more recent versions, well, the one I have, the slide I have in front of you is the most recent version of these EpiPens. And you can see on that slide, look down at the bottom of the pen where it says needle eject and there's an arrow. That's something that they've recently added, because even though they changed the design, patients or even nurses or other folks that were administering these, they were still clicking that button. So that orange section at the bottom, that's not where you activate the device. That's where the needle comes out. You would have to pull the cap off of the top, so that blue cap at the top, that gets pulled off, and then the patient holds this up to their thigh and presses down on the device, and that needle is going to come out of that orange tip. So again, even though they've redesigned it, you can see how people could still make mistakes, because it does kind of look like you're supposed to push on the end of that in order to activate the device. This is another version of another form of the epinephrine auto-injector. This one is called the AlviQ. It's going to be much more expensive than the one on the last slide, and even the one on the last slide is quite costly, possibly unnecessarily, but that's a whole nother discussion. But nevertheless, the AlviQ is more expensive. It's automated. It has verbal cues. So what the patient does is they hold the device, they take the end of the device off, and then they hold it up to their thigh, and the device will actually count down audibly to let the patient know when to remove the device from the thigh. So it counts down 5, 4, 3, 2, 1, and at the end of that sequence, the patient can remove the device from their thigh. I imagine that this device is much easier to use, much less likely to cause problems as compared to the first device. But like I said, this device, in general, these devices are very costly, hundreds and hundreds of dollars. I've seen them as high as $500 or $600, but this one's going to be more costly probably than the one on the last page. Okay, let's move on from the, to the next receptor, which is the beta-2 receptor. So we're still on adrenergic agonist, but now we're talking about those that activate the beta-2 receptor. Remember, you have 2 lungs, so these primarily are going to act on the lungs. The prototype drug is albuterol, or Ventolin is the brand name. Mechanism of action is activation of those beta-2 receptors in the lungs. Therapeutic use essentially is just as a bronchodilator. Some adverse effects that you could see: tremor, tachycardia, palpitations. These aren't surprising if you understand how stimulation of the adrenergic system and how those effects occur. We're not really going to discuss this further at this point. When we get to the respiratory module, we'll talk a lot more about albuterol. All right, adrenergic agonists that affect the alpha-2 receptor. So, when I talked about dopamine and dobutamine and phenylephrine, those drugs primarily activate alpha-1 and beta-1 receptors. We had albuterol that activates beta-2 receptors. And those drugs all had results or effects that you would expect. Remember, if you look at stimulation of the adrenergic system, you expect increased heart rate, blood pressure, bronchial dilation, and so forth. These adrenergic agonists, the alpha-2 agonists, actually are a little tricky because if you remember from our initial discussion, alpha 2 agonists are on the presynaptic nerve cell. And basically, the way these work is when you continually release norepi or epi, ultimately you've got a lot of epi and norepi in the synaptic cleft, and at some point there's so much there that you start to bind epi or norepi on the alpha 2 receptor on the presynaptic cell, and what that does is it shuts off norepi release. So while these drugs are agonists, their effects are actually what you would expect of an antagonist. So in terms of therapeutic use, hypertension, because they'll decrease blood pressure, because they don't, because it's the opposite effect of adrenergic stimulation. They can also be used for some centrally mediated processes such as narcotic withdrawal, pain, ADHD, and analgesia. Some adverse effects you may see: drowsiness, dry mouth, rebound hypertension, some CNS effects. You can also see orthostatic hypotension. The one I really want to mention is rebound hypertension. That one's really important. When you abruptly discontinue these medications, your blood pressure, your hypertension will not only come back, but it will come back in full force and rapidly. So because of that, you have to be sure to counsel your patients appropriately not to abruptly stop these medications. They do need to be weaned off. There are a variety of forms of clonidine, which is the prototype drug here, or Catapress or Doraclon are the brand names. It's available orally, it's available as a transdermal patch, it's also available for epidural use. And obviously the dosing is going to vary based on the different route of administration. Some of the nursing implications I think you should know: there is an abuse potential for this drug because of its central activity. It is on the Beers criteria list, so you have to be cautious in elderly patients when you use this drug. And then patch administration issues. This is one of the most common patches that's used, and there are just a variety of issues and errors that occur with transdermal patch administration. So let's go ahead and talk about those transdermal patch issues right now. And then as we talk about other transdermal patches throughout the course, you can kind of refer back to this list. Some of the issues that we see with transdermal patches: a new patch is administered, but the old patch never gets removed, which can be a problem because the old patches can hold some reserve of drug in them, so you could, in theory, overdose the patient. Rotation of application sites, so you have to rotate your application sites every time you administer the drug so that you don't have local irritation. Partial patches. Clonidine is one of the patches that can be cut. Despite it seems like it shouldn't be because of the type of patch it is actually able to be cut. So if you're using this patch in a child or even a small adult, a prescriber may ask you to administer part of the patch, and that can be problemsome if you've never cut the patch before. And just in general, partial patches can lead to a whole host of problems. Anonymous patches. So not all patches from manufacturers are appropriately labeled. So once you take them out of the overwrap and out of the packaging, they may or may not say on the actual patch what it is. And so if you have a patient that presents to your emergency department or presents to your unit and you don't know what the patch is because you weren't the one that placed it, and the patch itself has no markings, that could pose a problem. Unintentional overdose from heat. So if a patient applies a heating pad to their, where the patch is applied, or if they go into a hot tub or into the sun, they could overdose that medication because the heat's going to increase the rate of absorption into the epidermis. Proper disposal. So these have been associated with errors where they weren't disposed of properly and somebody else got the patch and either used the patch to divert drug, or maybe even children who take the patch from the garbage thinking it's a sticker and put it on themselves, and then they have an overdose of the medication. Adhesion failure, where the patch just falls off before it's due to be changed. And then, of course, electronic ordering, or EMAR. E just means electronic MAR, or medication administration record. So Because these electronic ordering systems are relatively new, they haven't always been designed well to facilitate proper administration and removal of patches. So that's something to look out for when you're in clinical practice. Moving on, let's now discuss the adrenergic antagonists. We've already talked about the adrenergic agonist. So adrenergic antagonists also act at a variety of sites, of receptor sites, either alpha or beta. So you have alpha blockers. Our prototype alpha blocker is phentolamine. The mechanism of action of phentolamine is alpha 1 and alpha 2 blockade. Therapeutic use primarily is just reversal of local vasoconstricting effects of extravasated alpha 1 agonists. You may remember alpha-1 agonists, dopamine, dobutamine, norepinephrine, epinephrine, phenylephrine. Those are the main alpha-1 agonists that we use for blood pressure support. If these drugs, which are given by a continuous infusion, extravasate, they can cause local necrosis of tissue, which is a serious condition. If you are monitoring them appropriately and monitoring the IV site, if it does extravasate, you can detect that quickly, and you can use phentolamine as a reversal agent for that issue. The drug would be administered regionally. It should be infiltrated around the extravasation site per your institutional guidelines. So let's move on to the specific alpha blockers. Prazosin, Minipress is the brand name, is the prototype alpha blocker, alpha 1 blocker. So this is specific for the alpha 1 receptor. Two therapeutic uses, benign prostatic hypertrophy or BPH, and also hypertension. These drugs are approved for use in hypertension. However, they are almost never used to treat hypertension. The primary use of these drugs is BPH. Some adverse effects you may expect to see. Orthostatic hypotension is by far the most serious, particularly in the patient population this drug is used in. It's used in BPH, which is something older males may experience. And these patients are, because of their advanced age, they are more sensitive to orthostatic hypotension. It's something that you have to monitor for and you have to warn your patients of as well. They're also associated with what is known as the first dose effect. The first dose effect is where you have probably about 1% of patients will lose consciousness within the first 30 or 60 minutes of taking the drug. So it's a pretty rare phenomenon, but it does happen. And the way you can overcome this, and we pretty much do this for all patients, is use a small first dose. So you use a relatively small first dose, maybe less than 1 milligram of prazosin as your first dose. So again, important to monitor and educate patients for the orthostatic hypotension, as well as, and I'm sorry, that says HTN on the slide. I'm going to change that to hypotension, as well as first dose effect. Name recognition slide. So other alpha blockers, they're all going to end in OSIN. So you can see some of the others on this slide. Tamsulosin is probably the most common one that's used. It's highly selective for the prostatic tissue. So this is the last of the drug classes in this lecture, but I gotta say, this is probably maybe the most important drug class, if not one of the most important drug classes that you'll learn in this course. And that is because these drugs are prescribed widely. Of all of the drugs that we talk about in this class, these drugs are right up at the top of the list for frequency of use. And there are quite a few uses as well. So we're going to talk about two drugs in this class of this class of drugs is called the beta blockers. The first drug we'll talk about, our prototype, is propranolol or Inderal. These drugs work by blocking beta 1 and beta 2 receptors. So we would say that these drugs are non-selective because they block both types of beta receptors. They're used for hypertension, they're used to treat angina, dysrhythmias, heart failure, and they can also be used for migraine prophylaxis. Specifically propranolol, because of its chemical structure, can cross the blood-brain barrier and it can elicit some effects in the CNS. These drugs have a lot of adverse effects, but I think if you look these adverse effects over, most of them will be logical. If you understand what happens to the body when you block beta receptors, both beta 1 and beta 2 receptors, if you think about the fact that when you block beta receptors, you are blocking the sympathetic nervous system. The sympathetic nervous system, remember, that's our fight or flight system. So we're going to get have the ability to escape from danger. It's going to mediate cardiac function and so forth. So some of these effects we might expect: bradycardia. Bradycardia is one of the most common problems that occurs with beta blockers, and it can be serious. Bradycardia can lead to AV block. It can also lead to reflex tachycardia. So the effects of the drugs directly on the heart can trigger some compensatory systems in the body, and that can ultimately lead to reflex tachycardia. Bronchospasm, we do worry about bronchospasm specifically with the non-selective beta blockers like propranolol. Remember, since it can block those beta 2 receptors in the lungs, when those receptors are activated, it causes bronchodilation. But when they are blocked, then we worry about bronchoconstriction and subsequently bronchospasm. And that is a real serious concern. We do avoid the non-selective beta blockers in patients who have a history of asthma or even COPD, because we don't want to put those patients at risk for bronchospasm. And then, like I mentioned, this drug crosses the blood-brain barrier, so we can see some CNS effects with this medication as well. Drug-drug interactions of concern, specifically calcium channel blockers. Calcium channel blockers, we will talk more about those when we talk about treatment of hypertension and treatment of angina and treatment of heart failure. Oh, well, no, actually not heart failure. Treatment of angina and hypertension specifically. And so the calcium channel blockers, they also cause bradycardia. So when calcium channel blockers and beta blockers are used together, they both can have direct effects on the heart, and they can increase the likelihood of bradycardia and potentially AV block. That's a big drug-drug interaction. The thing of it is, we use these drugs together all the time. So you guys, when you are monitoring your patients, when you're administering these medications, it's going to be really important to make sure you're monitoring for effects on the heart, especially when those two drug classes are used together. In terms of individual variation, I've already mentioned asthma, but let me mention heart failure briefly. You may notice that under therapeutic use, I have HF, which stands for heart failure. But then under individual variation, I've also listed heart failure. So here's the story with that. Beta blockers have been proven to improve mortality in patients with heart failure. The problem with the beta blockers is that they can also precipitate worsening of heart failure. And so we do use these drugs in heart failure, but we're very cautious. We use low doses. We titrate doses slowly. We monitor patients very closely because we don't want to push them too far with their beta blockade to the point where it causes worsening heart function. So in past semesters, students have had trouble kind of reconciling the fact that we use them for heart failure, but that they're also, we worry about patients with heart failure. We'll talk more about beta blocker use in heart failure, but for now, just keep in mind that they are beneficial for heart failure patients, but these patients do need to be monitored closely so that we don't push them so far that we worsen their heart failure. Some nursing implications: abrupt discontinuation of beta blockers can be dangerous. It can cause all kinds of reflexive issues, worsening of heart function, can cause rebound hypertension that's much worse than the hypertension the patient started out with. So that is something that we always educate patients about. So moving on to the selective beta blockers. The selective beta blockers like metoprolol, which is our prototype, the brand name Lopressor or Toprol, they are specific for the beta 1 receptors. So they are much less likely to cause bronchoconstriction or bronchospasm like the non-selective agents can. But with that said, I want you guys to know that even though these drugs are selective for beta 1 receptors when they are used at therapeutic doses, if we push the dose to the very high end of the dosing range, or if the patient receives an overdose, then that selectivity can be lost. And at those very high doses or in an overdose situation, drugs that are beta 2 selective at therapeutic doses can become non-selective. So they can activate beta 1 receptors. Well, they do activate beta 1 receptors, but they can also, in that setting, potentially block beta 2 receptors. So these work by blocking beta 1 receptors, but at that higher end of the dosing range, not only would they block beta 1 receptors, but they could potentially also block beta 2 receptors. Therapeutic use, very similar to the non-selective agents: hypertension, angina, heart failure, dysrhythmias, post-MI care. Generally, the selective beta blockers will be used in the setting of post-MI care for patients who have had a heart attack, again, because outcomes have been shown, morbidity and mortality outcomes have been shown to be improved in patients who are stable, who are receiving a beta blocker. Same adverse effects: bradycardia, AV block, reflex tachycardia. They could precipitate a worsening of heart failure. I think what I want to point out here is that you don't see bronchospasm, you don't see CNS effects. And that's because, again, at therapeutic doses, we would not expect to see bronchospasm. And most of the beta 1 selective beta blockers don't cross into the blood-brain barrier, so we don't necessarily see CNS effects as well. Individual variation, very similar: heart failure, asthma. Now, we don't worry as much about asthma with the selective beta blockers, but we should be cautious. In somebody that has very severe asthma, if they need high doses of the beta selective blockers, we might be a little concerned to the point where we might switch them to a different medication. So for kind of your typical doses, typical asthma patient, we wouldn't be as concerned, but when the doses start to creep up higher, or if we're a poorly controlled asthmatic, we might be worried. Drug-drug interactions, same thing as the non-selective beta blockers. We worry about calcium channel blockers, and that's because they both have those direct effects on the heart and can lead to bradycardia and AV block. And then again, nursing implications around warning patients not to abruptly stop these medications. These drugs do also have a name recognition. You can see there are 3 different OLOL, ALOL, and ILOL. These are all the endings, the suffixes that you'll see for the various beta blockers that are on the market. In the United States, there are 16 beta blockers that are currently marketed. In terms of medication safety concerns, these are considered high alert meds, but it's specifically the IV form. So not the oral form, but the IV form. And when I explain this, I think it'll make a lot of sense to you guys, because you guys have learned about the first pass effect. The IV beta blockers are subject, or I'm sorry, the beta blockers in general are subject to the first pass effect. So the dose of an oral beta blocker is going to be significantly higher than the dose of an IV beta blocker. And remember, that's because when you give the medication orally, the drug is going to be subject to the first pass effect, which means that when the drug is taken into the portal vein circulation, it'll be highly metabolized before it reaches systemic circulation. And we overcome that by increasing the dose of the oral form. But if you mistakenly give the oral dose intravenously, you will probably cause significant hypotension, significant AV block, and the patient will probably go into cardiac arrest at some point. So very, very important to recognize that IV adrenergic antagonists are considered high alert because of the risk of potentially giving the oral dose intravenously. So keep that in mind. Other reasons why these drugs are high alert, just in general, other safety concerns, not necessarily why they're high alert, but other safety concerns: mix-ups with the ER dosage form. So there are lots of different extended release dosage forms for these products, and they sometimes get confused with the immediate release. And if you give the if you give the extended release product 3 times a day when you meant to give the immediate release product, think about the fact that you're giving that patient a 3-fold overdose, and that is probably going to harm them. So being very cognizant of those dosage forms and the fact that they can get easily mixed up with the immediate release dosage forms is very important. Finally, Sotalol, which is one specific beta blocker, is on the Beers list because it can cause problems for elderly patients. Okay, so that is the end of our lecture today, and hopefully this was helpful. If you have questions, please post them to the discussion board and we will be monitoring that. Thank you for listening.